Yeah. Good morning, sir.
Good morning. Good morning.
Yeah.
Good morning, Dr. Shivanand. Shyam, good morning, Shyam.
Morning.
Okay,
So, with the blessings of His Holiness Jagadguru Shri Shivaratri Deshikendra Mahaswamiji, I hereby welcome all the delegates and our keynote speaker, Dr. S. Venkatesh, for today's webinar, which has been organized by the Special Interest Group on Management of Medical Problems and Medical Emergencies in Dentistry, JSS Academy of Higher Education and Research. Today's webinar topic is on implications of hepatobiliary and renal conditions on dental treatment. So the dental surgeons are increasingly encountering patients with renal and liver diseases. Most of these patients will be either on dialysis or on long-term medications and would have undergone either renal transplant or liver transplant procedures. So these patients require a special care involving preoperative and post-operative dental treatment modifications in order to reduce or avoid medical problems during the dental or surgical procedures. Today, in this webinars, we shall discuss these issues by our keynote speaker, Dr. S. Venkatesh. So our keynote speaker, Dr. S. Venkatesh, is a consultant urologist from Coimbatore. He will be giving a talk on implications of hepatobiliary and renal conditions on dental treatment. Dr. S. Venkatesh has completed his MS in general surgery and MCS in urology. He is a well-known academician and a clinician in South India. He has obtained the title of Member of Royal College of Surgeons, Emergencies from Edinburgh. He has special interest in endourological procedures and challenges they offer. So now I hereby request our keynote speaker to Dr. S. Venkatesh to kindly deliver his talk. Over to you, sir.
Okay. Thank you, Dr. Shivanand, for those kind words. Thanks for inviting me. I think, am I audible?
Yes, sir. Your voice is very clear and audible.
Okay. Thanks to you and your team. A special thanks to Shyam, who's my childhood friend from Coimbatore. So when he called me and asked me to talk on a topic, which I mean, it's offbeat topic for us as a urologist. So when I went up, I read up. I think it can be more of an interactive session rather than a one-way talk. So at any point, if you feel like asking any question or anything, I think I would be happy to go ahead and answer your questions right away. Whenever you want, you can just interrupt me. There is, if I'm going, I mean, if it is too, if it is too basic or anything, you can start asking anything. I mean, let it be an interactive talk. Let it not be a one-way affair.
Yeah. And I also request these attendees, if they have any questions, they can post their questions in the chat box.
Definitely, I would be willing to take them right away. Okay, so basically I was asked to talk about two things: implications of hepatobiliary conditions and renal conditions on dental treatment. So I think we would start off with the renal conditions first. So there are two slide sets actually. I've just put it into two. So the topic which we are going to start off speaking is about the implications of renal conditions on dental treatment. I'm Venkatesh and I will be taking you through this topic. Yeah. So see, the first and the foremost thing that we learn in medicine is primum non nocere, which means first do no harm. Okay, so why is this very important? Is because whenever you treat a patient which you don't usually see, you need to have a complete knowledge about the condition that you're dealing with so that you don't do any harm. So before you embark on any procedure in a patient who has got a comorbid condition like a renal condition, we need to know about that renal condition. So that is why this topic is very important. So as a dentist, what are the renal conditions that you would be coming across commonly? It would be chronic kidney disease. So by chronic kidney disease, what do you mean? Now, chronic kidney disease basically means that there is a decrease in the renal function, which would be shown by a raise in the serum creatinine level. Usually we see 2, 3, 4 serum creatinine levels as a slow rise, and then they go into end-stage renal disease when the creatinine reaches 6, 7, where the creatinine clearance, as we call it, goes less than 10. So at end-stage renal disease, patients need dialysis as their primary form of management. So that is one condition which you will be seeing. Other common condition which you will be coming across is in a patient with a pre-transplant workup. So a patient, the treatment of end-stage renal disease is basically renal transplantation. And before renal transplantation, patients are always sent to the dental surgeon so that they see them, they work them up, and then they see what all are the things that they manage. So what are all the things that they have in their oral this thing, so that if there is any need for any surgical procedure, they complete that before we do transplant, because we're going to give immunosuppressive drugs after transplant. And so we need to have a proper follow-up for those patients. And there is an increased chance of infection if you do any procedure post-transplant. So better to finish the oral conditions before. So about this pre-transplant workup, this is what I would speak about later in the discussion. If you need any further questions, I'm ready to take it. So regarding the chronic kidney disease patient, who is basically an end-stage renal failure patient, and a renal transplant patient who has undergone renal transplant, about his management, these are the two things which we will be covering in this talk. So, I mean, whenever we start a topic, we'll have to go to the basic pathophysiology. So to understand the basic pathophysiology, we have to understand the physiology of the kidney. So as we know, what are the functions of the kidney? The most important function being elimination of metabolic waste. So this is the cross section of a kidney. As you know, I'm using the pointer now. So this is the renal cortex, this is the renal medulla, and this is the collecting system, this is the renal pelvis, and this is the ureter. So this part of the kidney, when it is enlarged, this is how it is seen. This is basic functional unit of the kidney, which is a nephron. So this nephron is enlarged here and shown. So the blood from the renal artery comes to this afferent arteriole, which is basically the blood flow from the aorta. And this blood is filtered across a membrane, which is called as the Bowman's capsule, the Bowman's space, and the glomerulus. So this whole thing, which is called the renal corpuscle, filters the blood and then produces a liquid, which is basically urine. This urine goes through this tube, which is called the proximal convoluted tubule, which comes to the loop of Henle, and then the distal convoluted tubule to the collecting duct, to the complete collecting, multiple collecting ducts joined together, and then they get into the renal pelvis and come out as urine here. So this is the basic physiology in a nephron, and this is where the whole exchange of the electrolytes and everything takes place. So this is the basic structural and functional unit of a kidney, and this is how it happens. So why is this important? Because when we lose kidney function, there is severe electrolyte imbalance. So there is severe electrolyte imbalance when we lose kidney function. So what is the next important function of the kidney is there is also calcium homeostasis, which is part of the kidney function. So why is that important? Because there is a secondary hyperparathyroidism. There is bone, there is a hypercalcemia in the blood when you have a renal problem. And then you also have erythropoietin production, which is a very important function of the kidney. Erythropoietin is important for the RBC production. If it is not there, patients develop anemia. Anemia is a definite problem in CKD. So that is managed by giving injection erythropoietin. The renin-angiotensin mechanism is very important for control of the blood pressure, which gets deranged in renal failure, and all renal failure patients have got uncontrolled hypertension. Unless they are on proper drugs, there will be a very high blood pressure. So these are the things which you should remember. Okay. So then coming on to the, so this is the basic physiology of the kidney. Then coming on to the investigations that we do in a case of renal failure, these are the investigations that you should have before you proceed to renal failure, to management. You should have a blood urea serum creatinine, You should have a serum electrolytes because they might be deranged. A very high serum potassium can be a trigger for arrhythmia. So that is one thing which is very important. You also have a very, importance of the platelet count. So the platelet count, because a low platelet count can be a trigger for bleeding. The PTINR should be done before any invasive procedure is done, APTT, to see whether there is an increased bleeding tendency, activated partial thromboplastin time, the prothrombin time, and the INR. So if you suspect sepsis, then definitely we have to do procalcitonin and CRP also. So these are the investigations that we do. Of course, we do a routine hemoglobin also, because if the hemoglobin is low and there is a chance of a bleeding, then we'll have to be careful about it. These are the investigations. So what are the exact manifestations of CKD in dental practice? I think this you would be better versed than me, but then it is my duty to tell about that also. So yes, so 90% of the patients will have dental manifestations in CKD. That's a very high number. So as we just now mentioned, the kidney function in controlling hypertension as a homeostatic mechanism. There is a chance of an infection and drug problems and anemia. All these things can happen in CKD. So the first and common thing which the patient may present with is a uremic fetor, which is basically halitosis, a very altered smell in the mouth. So that is due to production of ammonia. There is an increased level of urea in the blood, which gets secreted in the saliva. And when the enzymes act on urea, they break down to produce ammonia, which gives this bad breath. There is an unpleasant metabolic, there is an unpleasant metallic taste in the mouth. And there is an altered sensation because of a neuropathic and change in the pH in the mouth. There is an altered sensation. It can produce some pain and ulcers. Dry mouth is a very common thing in CKD. That is because all CKD patients are advised to have a very reduced fluid intake. So when they drink only about 500 to 600 ml of water a day, their mouth is always going to be dry. And there is also minor salivary gland atrophy, which happens in CKD. So that also causes a dry mouth. So if you see their mucosa will be pale, which is because of anemia. So these are a few pictures. There is something called uremic stomatitis and enamel hypoplasia in children. I think you would be better versed with all these things. So these are things which you see, and these are all manifestations of CKD in dental practice. Okay. Okay, just a minute. I'm sorry. என்ன மேனக்கா மேனக்கா க்ளோஸ் பண்ணுங்க மேனக்கா சாரி க்ளோஸ் பண்ணுங்க இங்க பேச வேண்டாம் okay sorry I'm sorry yeah so clinical manifestations, as we said, is uremic stomatitis and enamel hypoplasia in children. You also have caries and periodontal disease. You can have bone problems because of demineralization, lytic lesions on the X-ray. There can be jaw fractures. Patients also have a bleeding tendency that is basically due to chronic kidney disease. Patients are also dialyzed regularly. In hemodialysis, we use heparin. So on the day of dialysis, it's better not to do a procedure. The best time to do a surgical procedure is the next day, because the half-life of heparin is about 4 hours, and you can time the procedure accordingly. So how do you manage CKD? So what you have to know about management of CKD is 2 things that we do commonly. One is the hemodialysis. Most of the patients will be on hemodialysis. So this is the picture of the hand, where you have an artery and a vein, which are anastomosed by an AV fistula. And the vein dilates, thereby producing a very high flow. So inside this vein, we plug 2 cannulas, one for one which is called the arterial line, and the other which is called the venous line. So through this, blood circulates, through this filter, the blood circulates, and this does the job of the kidney. So this happens at least 3 times a week on patients on hemodialysis. So on those days, patients will be given heparin. So if there is any surgical procedure that you are planning to do, it's best to do on the next day, because these patients usually will have difficulty in breathing, difficulty in in lying down supine, so all those things. So the best time to do would be the next day, because after the next day they would be the healthiest. Before the dialysis is due, they would be a bit breathless. So the best time to do would be the next day after dialysis. Okay. So what is the other method of dialysis that we do? The other method is called the peritoneal dialysis, in which we put a tube, which is basically a catheter, inside the abdomen, and the other end of the catheter is available outside. So that is maintained well by the patient, and during his sleep, patient is being put on a peritoneal dialysis, or during the daytime. In an automated machine, they can do it during sleep. In a manual thing, they would be doing during the daytime. So daily, they connect bags which send the fluid inside the peritoneal cavity, and across the peritoneal membrane, the fluid exchanges, and the dialysate which comes out contains all the waste products of metabolism. So this happens in the peritoneal dialysis program. So in these patients, there is no need to wait for any day for a procedure. You can do it as and when you wish. Okay, this is about the management of CKD, which you should be knowing. So what are the management concerns when you see a patient? You should be careful about bleeding. So that is why we do a PT, INR, a platelet count, a hemoglobin before the procedure. Even otherwise, if there is bleeding, then you should be having enough material. To stop the bleeding, be it hemostatic material like oral application, topical applicants, methods to give pressure to stop the bleeding, all those things you should be ready with. Uncontrolled hypertension is a big problem during your practical procedures. So the pre-procedure BP is very important. If the patient has got high BP, there are various drugs that you can give, especially Arcamin is a very important drug which the CKD patients receive. So these drugs, on the day of the procedure, you should ask the patient to take these drugs when they come to you. So the other thing is anemia. You will see a lot of anemic patients in your practice because of CKD. Drug-related problems. What are the drug-related problems? See, in a CKD patient, a lot of times we will not be able to manage the drug problems. So we have to see what drugs they are on, and then see whether there is a drug interaction with the drugs that you give. The excretion of the drugs is through the kidney, a lot of drugs. So we'll have to be careful about what drugs we use. There is an increased chance of infection in a CKD patient. So antibiotic prophylaxis is routinely given whenever you do any procedure on a CKD patients, especially in cardiac patients with valvular problems. In CKD, there is an increased incidence of valvular problems because of calcium deposition. So the drug dosages in CKD patients will be, I'll be speaking about it now. So whenever you give an antibiotic in a CKD patient, what is the best drug to be given? We prefer penicillin group, cephalosporins, clindamycin. Azithromycin also does not need a dose adjustment. So amikacin is totally contraindicated, and drugs which are basically excreted through the kidneys are a problem. So regarding the antifungals, amphotericin, when in a severe renal failure, it can cause very big problems. So we'll have to be very careful when you give. And fluconazole, yes, definitely you can give at a reduced dose, basically. Regarding analgesics in renal failure patients, paracetamol can be given safely, but NSAIDs are a big problem in this. Not because anyway they have got renal failure, so giving NSAIDs may not cause a problem, but NSAIDs induce hypertension in these patients, and that would be a cause for trouble. So that is why NSAIDs in a CKD patient should not be used. So it's better to manage pain with paracetamol and tramadol. So in a patient who has got CKD, who's on certain drugs like antihypertensives, diuretics, and beta blockers, they can cause lichenoid disease in the oral cavity. So this is about basically the medications and what effects they cause. So immunosuppressive drugs, we know, can have an increased chance of infection. And this is a picture of CMV infection and HSV infection of the oral cavity. So in a renal transplant patient, what are the things that you would see? In a renal transplant patient, This is the most common thing that you would see, and which they will be referring the patient to you for management. I think this can be managed surgically also. So this is gingival hyperplasia, which happens because of the dreaded drug cyclosporin, which is a mainstay in transplant. But luckily now the incidence has really decreased because the drug that we use now is tacrolimus, and that does not cause this gingival hyperplasia. But during the cyclosporin era, 30% of patients who had cyclosporin had gingival hyperplasia. There are other drugs like calcium channel blockers, anticonvulsants, which can add on to this occurrence of gingival hyperplasia. Nifedipine with cyclosporin can cause 50% incidence of gingival hyperplasia. The pathogenesis, they say there is a genetic predisposition, there is drug and how it acts on the body. Plaque-induced inflammation can also be a cause. Improvement in oral hygiene reduces the incidence. And the good thing is when we change cyclosporin to tacrolimus, this is stopped. The incidence is very less. What are the other things that can happen? In chronically immunosuppressed patients, you can have Kaposi sarcoma, which is basically because of human herpes virus 8. So this is the Kaposi sarcoma lesion. You can also have hairy leukoplakia. This is due to Epstein-Barr virus. So to give you in a nutshell, what are the things that you will see during a management of a patient of CKD? This would be basically a take-home slide. So always speak with the nephrologist before you proceed with any procedure on a CKD patient. There should be an accurate medical history because it's very important to know what medications the patients are on. A lot of CKD patients will have an associated cardiac disease, which you will need to stop the antiplatelets. There is a very high prevalence of arterial hypertension, which I have already spoken about. You need to control the blood pressure well. There will be platelet dysfunction and anemia. So your hemostatic study should be done. That is PTINR, APTT, platelet should be done. And you should plan the surgery well. Okay. There can be local hemostatic measures which should be available with you. Heparin anticoagulation. So you should see that they have not received heparin on the day of the procedure. So the mean half-life is about 4 hours. So it's better to do the procedure on the next day. So there is this vascular access for hemodialysis. As I showed you in that picture, it will be usually in the left upper arm, upper limb, basically. So it can be either in the wrist or it can be in the elbow. So that should not be compressed when you're using a blood pressure monitor or when you're administering any drug. It should not be, that hand should not be used. So there can be disturbances in the metabolism and removal of drugs. Some drugs may be prescribed. You need to dose adjust those drugs. Then there can be, the bone will be more susceptible to fractures. You need to be careful when you do a dental extraction to avoid those fractures. In a patient after renal transplant, what are the things that you should be careful about? Again, the patient still can have hypertension, they can have platelet dysfunction. The other special things about renal transplant recipient is patients will be on corticosteroid therapy. The dosage is very important when you manage them. If they have less than 7.5 milligrams of prednisolone, then they don't go into adrenal crisis. Otherwise, we need to give supplemental corticosteroids during your procedure. So in immunosuppressed patients, antibiotic prophylaxis is very important. You should not miss them. There is drug disturbances so as we know, these drugs which are given for immunosuppression, usually we give tacrolimus, we give mycophenolate mofetil and corticosteroid. So all these drugs can have drug interaction. So we should be careful about what drugs you give. So cyclosporin and nifedipine can cause gingival overgrowth, which can be managed. So this is about the renal part. I would be happy to stop here and ask for questions if there are any. Dr. Shivanand?
Yeah, thank you, Dr. Venkatesh. It was a very interesting and very good session. So thank you. So we have a few questions which has been sent.
Okay.
like a few dentists wanted to know whether is there any absolute contraindication, because in dental surgery the most commonest procedure what we do is tooth extraction by using local anesthesia.
Yes.
So is there any renal conditions which is possesses an absolute contraindication for dental extraction, or
No.
in that case what we need to?
No. See, actually, the only thing what you'll have to check preoperatively is, as you do always, whether patient is on any antiplatelets, which you would stop. Because a lot of CKD patients will have renal, will have a coronary disease also. There is no absolute contraindication at whatever level of renal failure. If the patient is otherwise well preserved and otherwise fit for a procedure, you can give local anesthesia and extract teeth. See, all CKD patients, before we do transplant, we send them to the dentist here. That's our usual routine protocol. So if there are any caries teeth, anything, we extract it before the renal transplant, because after that we will start them on immunosuppression. So they will have an increased chance of an infection. So that is a routine practice, and I don't think there are any absolute contraindication. The only absolute contraindication would be bleeding diathesis. But bleeding diathesis can always be managed in a renal failure patient. It will be either because of platelet dysfunction, so in which case you may need to give platelet transfusions. If it is absolutely necessary, no dental procedure is per se contraindicated in a patient with renal failure unless he's physically unfit for the procedure.
Okay, thank you, doctor. Actually, one more. The next question was actually regarding that fitness, which like basically dentists, they wanted to know what is that
we look
expect.
for.
And, we look for when you
Yes.
ask. And I think you already told that caries teeth needs to be extracted. And maybe
a general look at the oral hygiene is very important, because from the nephrologist point of view and the urologist point of view, they don't want the mouth to be a harbor for bad bacteria. So a general oral hygiene is what we are looking at. If there are any things against general oral hygiene, which I think you would be experts about, I think we need to manage them. That is what a general oral hygiene, and obviously for caries teeth. These are the two specific things which we'll be looking for when we send a patient to you for reference.
Okay. Is there any conditions where which requires a dental surgeon to maybe shift the patient to an or do the dental extraction or procedure in hospital setup? Is there any?
See, actually, per se, if you're doing a tooth extraction and all, I don't think you need to shift the patient. But if you're doing any major renal major surgery in a patient, then definitely, yes, it has to be done in a hospital setting in a CKD patient, because patient may anytime during or after anesthesia may require a dialysis. See, whenever you anesthetize them, there can be a chance for a desaturation and all those things. So for that procedure only, you will need a backup of dialysis.
Okay. Okay. And another, I think, one more question was asked regarding this prescription of antibiotics analgesics, I think, which you already mentioned in your talk.
See, generally speaking, I would say antibiotics, the best would be cephalosporins. I think all of you are comfortable prescribing
we
cephalosporins.
Generally give amoxicillin with clavulanic acid and some aceclofenac.
Aceclofenac. Yes, that's what I said. No, aceclofenac should be avoided in a renal failure patient. The reason is, anyway, as you know, that he's a renal failure patient, but aceclofenac can induce hypertension in a renal failure patient. And uncontrolled
diclofenac as well.
Diclofenac, aceclofenac, all the NSAIDs, apart except paracetamol. So the best thing would be to give. We have a 1 gram tablet of paracetamol.
Okay.
Along with tramadol.
Yeah, tramadol. That's what you told in your talk.
That would be the best combination to give for pain.
Yeah. And antibiotic, we generally give amoxicillin with clavulanic acid. That should be fine.
That should be fine. But clavulanic acid has not got a very good renal excretion, actually speaking. But then plain amoxy would be better, or cefpodoxime, cefixime, all those things are better drugs than plain amoxicillin. Because if you can avoid adding clavulanic acid, it would be better. Clavulanic acid and sulbactam have got a small problem with renal excretion.
Okay. Thank you, doctor. So is there any other questions from the attendees? So before proceeding to our next regarding hepatobiliary implications. You can post your questions. So in the meanwhile, you can start, sir, with your next.
Okay.
Do you?
Okay, can I go on to the next presentation?
Yeah, yes, sir. Yes.
Yeah. Okay. So yeah, again, I will start off with the same thing. As I said earlier, we should understand the disease before we treat it. So we should know about hepatobiliary conditions, which we will come across to treat your dental patients better. So that is the idea of this whole talk. So see, regarding liver conditions, we can classify them into two. There are two kinds of classification of liver conditions. One is an acute hepatitis, the other is the chronic hepatitis, and there is an infective etiology for renal dysfunction, and there is a non-infective, of liver dysfunction, and there is a non-infective etiology for liver dysfunction. So what is acute hepatitis? Acute hepatitis is basically reversible. And usually it commonly happens because of hepatitis A. The other type of hepatitis can also be reversible. But a lot of other type of hepatitis, that is hepatitis C or hepatitis B, can go into the irreversible chronic state, about which we'll be seeing later. Okay. So now, the infective hepatitis, as we know, is usually the infective hepatitis, as you know, is usually viral, and it is due to A, B, C, D, E, as we know the viruses. And non-infective can be drug-induced alcohol-related hepatitis is possible. So first, a few words about the function of the liver. What are the functions of the liver? Most of the proteins in the human body, albumin, coagulation factors, hormones, growth factors, everything is synthesized in the liver. And the bile and its transport happens in the liver. There is a regulation of nutrient metabolism, glucose, glycogen, lipids, amino acids, everything happens in the liver. Metabolism or excretion of a lot of drugs happen in the liver, especially paracetamol. So these are the things on the background which you should have when you treat a patient with liver dysfunction. So what are the consequences of liver cell damage, especially in the point of view of a dentist? There will be definitely an increased chance of bleeding because of vitamin K deficiency. Platelet consumption can occur in splenomegaly. See, a lot of patients with cirrhosis develop splenomegaly because of portal venous hypertension. So this splenomegaly causes the platelets to be consumed and hence cause disorders of hemostasis. So there can be more bleeding whenever you do any procedure. So there can be vitamin K deficiency. So in liver cell failure patients, we give vitamin K before we proceed with surgery on those patients. So there can also be altered drug metabolism. Drugs like paracetamol, simple paracetamol, cannot be used in these patients. There are other drugs which the serum levels of these drugs will alter tremendously when we use them in patients of liver cell failure. So there can also be transmissible diseases. So because patients can have hepatitis B, hepatitis C, which are very, very dangerous to the surgeon. So what are the investigations like we saw for the renal patient? What are the investigations that we do before we touch a patient of liver cell problems, liver failure, or a cirrhosis patient? We need to know the bilirubin, the direct and the indirect bilirubin. We need to see the enzyme levels, the aspartate transaminase, alanine transaminase, alkaline phosphatase, and the gamma glutyl transferase. So all these enzymes are very important to see how the kidney is functioning. Each one has got a specific role. Alkaline phosphatase shows obstructive lesions in the biliary tree. Gamma glutyl transferase shows the alcoholic liver disease. AST and ALT generally show a score for the hepatitis. So we should always do a PT-INR APTT before any procedure. We always do a platelet count also. And this fibroscan is a scan which is done on the liver to see how much of the liver is affected by cirrhosis. If you are suspecting hepatocellular carcinoma, we do alpha-fetoprotein in them. So these are the specific investigations apart from the routine investigations that you do when you see a patient with liver problems. So before you touch these patients, you should have this investigation. You should have a basic understanding of what severity of the liver failure that the patient is in. Very mild liver dysfunction need not be bothered about. But if the dysfunction, there is a child pug score, which is beyond the purview of this topic. So if severe liver dysfunction is there, then we should be careful. So we should know about the diseases before we go ahead. So the most common thing which you would encounter is viral hepatitis. As you know, the hepatitis A is transmitted to the fecal-oral route. It is usually self-limiting, does not cause much of a problem, occurs commonly in developing countries, and it's an RNA virus. There is no carrier state. So it's diagnosed by the serological testing. There is only conservative management, and the vaccine is available. So if a foreigner is actually traveling to an endemic area of hepatitis A, they take that vaccine. So from a dental point of view, hepatitis A may not be very important, but you will see patients with hepatitis B. So whenever you see a patient with hepatitis B positive report before a routine surgical procedure, what do you do? Do all patients with hepatitis B positive need a detailed workup by a gastroenterologist? No. If the liver function is normal, a basic dental procedure can be proceeded with, and later the patient can be referred to a gastroenterologist for further management. It's highly prevalent in the society because we see that a lot of hepatitis B positive patients we come across. It's a DNA virus. The important thing for the dental surgeon to be careful about is it spreads through both hematogenous route and also through the mucosal absorption, rarely. Okay, so whenever you have a cut in the mucosa and you are very closely doing a surgical procedure and there is a cut in your gloves, it becomes very dangerous. So obviously the basic barrier method of double gloves and all those things should be very, very closely adhered to. And dental surgeons, because they are very closely exposed to blood, they should always be careful. And I understand that routinely before you do a dental procedure, you don't do a Hep B testing. So you should treat all patients as hepatitis B positive, actually speaking, because you don't know which patient is hepatitis B positive when you do a procedure. So, so what is that you should know about the disease hepatitis B? See, seroconversion is 30%, which means that if you get inoculated by hepatitis B virus by hematogenous route, the chance that you will become hepatitis B positive is only 30%. The rest 70%, the body fights the disease and gets it out. So without developing any chronic sequelae of the disease, 90% would be completely okay. So when the seroconversion is 30%, the rest of the 20%, 10% will grow into a chronic state, which complications like cirrhosis, carcinoma can occur. So the overall prognosis for the disease is good, but in this 10%, it will be a problem. Okay, so how is it diagnosed? We do HBsAg antigen testing before any surgical procedure in the general surgery background, and the very specific diagnosis is done by HPV DNA to see the viral load and what treatment can be given. Now various drugs are there. So what is the answer to this problem of hepatitis B in dental practice? Every dental surgeon should be vaccinated completely, and you should check your antibody status regularly. At least our infectious disease specialist says that you should check it at least once in a year or once in 2 years. You should check your the antibody status. So you should be completely vaccinated for hepatitis B. What about hepatitis C? Though hepatitis C is lesser in prevalence, it's more dangerous. Why? Because 85% of patients who develop can go into chronicity, which means they have got chance of going into chronic liver disease. They can have hepatocellular carcinoma. So the thing is, it is again through blood spread, and we don't have a treatment for that. So very important that you take all precautions to avoid hepatitis C infection. So usually in the first 2 decades, when anybody gets HCV positive, they're asymptomatic. Now a lot of drugs are there which can be used to treat it. Then they develop symptoms of liver failure, and extrahepatic manifestations in hepatitis C are also very common. cryoglobulinemia, porphyria, sialadenitis, lichen planus, diabetes mellitus, peripheral neuropathy can all happen in hepatitis C. So it is diagnosed by HCV antigen and RT-PCR to look at the viral load again. So there is no vaccine. Medical therapy is effective. So if somebody is unfortunately diagnosed, you can send them to the gastroenterologist and they can give medical therapy for the disease. So now we are coming into a condition called chronic hepatitis. This may be due to anything, hepatitis C, hepatitis B. So, and this is more than 6 months. There is diffuse inflammatory lesions in the liver. It is slow to progress, but there will be a rapid decline in the last stages of the disease. It leads to cirrhosis and hepatocellular carcinoma. There is poor outcome. So in a fit patient, definitely liver transplant has a role. The other common thing which you might come across is alcoholic liver disease. It's one of the 10 most common causes of death worldwide. So regular excessive drinking is the cause. So when somebody has got alcoholic liver disease, does it mean that they are doomed to go into liver failure? No. In a stage of fatty liver, it is reversible. In a stage of cirrhosis, it becomes irreversible. So in cirrhosis, the outcomes are very poor. So if somebody is as an alcoholic and you have a fatty liver on ultrasound, they should immediately stop drinking. So what is cirrhosis actually? Cirrhosis is irreversible formation of fibrous scarring in the liver. It can be due to Hep B, Hep C, alcohol, and various other causes. It can lead on to liver cell failure, hepatocellular carcinoma, portal hypertension. The management is basically liver transplantation. So there is something also called as non-alcoholic fatty liver, where fatty liver occurs without the presence of any other major problems. So it can be associated with obesity, diabetes mellitus, hyperlipidemia, and insulin resistance. There are no clear treatments for this problem. So you'll have to basically eliminate risk factors. You have to reduce your weight, you have to control diabetes, you have to treat yourself for hyperlipidemia. So when a patient has got a HCC, he comes to you for a dental procedure. What should you know about it? See, the thing is, you should always check for hepatitis B and C in those patients, which should have already been done if they have been diagnosed with HCC. And their liver cell reserve should be looked at before you proceed to any invasive procedure in a hepatocellular carcinoma patients. When it is associated with cirrhosis, death is almost inevitable. So what about the oral manifestations, clinical manifestations of liver failure? So everywhere it will be coated yellow, as you know. There can be bleeding disorders because of disorder of the vitamin K metabolism, disorder of coagulation factors production, and all the other problems. There can be, just like you can have a uremic fetor, you can also have a uremic hepaticus. You can have cheilitis, you can have a atrophic tongue. There can be chronic periodontal disease. There can be xerostomia. So sialadenitis, especially in patients with alcoholic liver disease, this is a typical picture where you have an enlarged parotid gland. The pathophysiology, they say, is because of peripheral neuropathy causing disordered release of saliva. So that is the supposed pathophysiology. You can also have xerostomia, which can lead to caries, soft tissue infections, and later candidiasis. There is a dangerous triple association in especially HCV disease, along with Sjogren's syndrome. We also see lymphoma of the salivary glands in these patients. So liver cell failure can be associated with lichen planus also. So what about the dental management? The most important thing I would again and again stress upon, as I stressed upon earlier, is you don't routinely do hepatitis B or C checking before you do a procedure. So you will have to consider everybody as positive, because especially hepatitis C is extremely dangerous. You should be very careful so that you don't get into contact with any blood of the patient. So the other thing is, obviously the bleeding risk is there in a liver cell failure patient. So you will have to, if the bleeding parameters are deranged, it's better to do the procedure in a hospital, and you will have to monitor, maybe put the platelets or platelet-rich plasma or the other things which will help you to stop the bleeding. There will be drug metabolism changes also, so you will have to be careful about what drugs you prescribe. So a word about hepatitis C virus per se, it remains stable on the surface 5 days in room temperature. So we will have to clean after you do a suspected hepatitis C positive patient procedure, you will have to clean the surface very, very, very carefully. So what are the practical issues that you should take care of? Strict asepsis is very important. Conventional method of sterilization, like using a sterilizer, can take away the Hep B and Hep C virus. So it should be used. You can use barrier nursing and sterilization. In case of accidental perforation by sharp objects, what is that a dentist should know of? Okay, the first important thing is whether you have had double gloves. A double gloves reduces the chance of you getting the Hep B or the Hep C by multiple times, because to prick both the gloves and then for the needle to go in, it would be very, very unusual. Okay. The other thing is hollow needle versus blunt needles. A blunt needle has got a lesser chance. A hollow needle has got a higher chance. So if you are pricked, pray that you are pricked by a blunt needle. Okay, the least chance of getting infected is by mucosal exposure. That is basically to the eyes or to the oral mucosa. They've got a very less chance of exposure. So what to do? So wherever you get exposed, you have to do a thorough washing with soap and water without rubbing, because they say that the viral particles there can get into the system if you rub. So with a flowing water, fast flowing water, you clean the place completely. And there are people who say that pressing, if you get an injury here, you can press here so that all the blood comes out. But it is more of a physical thing rather than a real help to you. So the viral markers, I don't think, though, whether you do or not, I do not know. But then viral markers, if you can do before any real interventional procedure, you can take very good precautions. So vaccination should be universal for HBV, hepatitis B virus, because that is something which we can, which we can take care of, and we will have to check antibody status regularly. So what are the tests that you do? You do a bleeding time, a prothrombin time, a thrombin time, a thromboplastin time, and APTT, basically, a platelet count, and the INR. So these are the normal values. So you should speak with the liver physician before you embark on a procedure. All these tests should be done. Acute liver failure, severe acute hepatitis, and deranged coagulation profile. Surgery can be done only after correction. So these are the absolute contraindications for a dental procedure. So any abnormality in LFT, you have to discuss, and then surgery should be postponed. Emergency surgery should be done in a hospital setting, preferably. And what about drugs and liver failure? Yes, local anesthetics are importantly metabolized in the liver, but you can give anesthesia. They're not going to be go into the bloodstream. So you can use local anesthetics. Analgesics, as I said, paracetamol can be used in a small dose, but we'll have to use very carefully in a patient with severe liver failure. So, so in these cases, I would prefer tramadol to be given. So the diazepam and barbiturate should be avoided. Erythromycin, clindamycin are all metabolized in the liver, so they have to be avoided. Ketoconazole, fluconazole needs to be avoided as much as possible. So the severity of the liver failure is important. If it is a very mild liver failure, then we may not really do much. So erythromycin, metronidazole, clindamycin should be totally. Cephalosporins are again safe here. NSAIDs, again, they say to avoid completely because the part of the metabolism will happen in the liver. So tramadol can be used sparingly in these patients. Yes, sir. Thank you. I think I finished with that.
Yeah.
Yeah. Okay. Yeah.
Thank you, Dr. Venkatesh. It was very, very informative and a very precisely made talk, which was exactly relevant for most of the dental practitioners. So most of the, actually, there are a few questions for which you have already answered in your presentation. But still, there could be some slight questions.
Please.
Yeah.
Please go ahead.
So, what one of the dentists wants to know, immediately after doing some extraction, post extraction, immediately there is a severe bleeding from the extraction socket. So what medications or any procedures maybe
See,
you recommend?
in a practical setting, okay, if you have not done preoperative platelet count, uh, uh, and the other parameters, PT, INR, and all those things. So if you have not done them, then definitely you will have to send those investigations immediately. But practically speaking, I think pressure is the first thing that you can apply, which anyway you would have already done. Local hemostatic agents can be tried, but then they may not be really effective if it is a spurter. Otherwise, you'll have to shift the patient to a higher center and use cautery or take a suture or something like that. Because immediately just blindly giving platelets, platelet-rich plasma or any transfusion per se may not really change things. Because I mean, if you had known earlier that the platelets were low, no, definitely you would not have taken the procedure, the patient for procedure. So in such a situation, I would recommend that first you send investigations, do local measures, and then try to treat the problem. Because see, if the PT-INR is high, the platelets are normal, then you will have to give vitamin K, but vitamin K is going to act only after 3 days. So you will be actually in a pretty bad situation, actually, if you encounter bleeding because of liver cell failure, if you have not recognized it. So the best way is actually to prevent it. In a liver cell failure patient, if you're, I mean, I don't think you would venture to do anything so major. So anybody who walks in, no, I think we should have, as they say, the general physical examination, the basics of all our medical teaching should be adhered to. Then you will not miss a situation like that.
What is your opinion regarding use of local tranexamic acid in the form of soaked in cotton or a mouthwash?
Yes. See, actually, I do not know about specifically about dental procedures, but in urology, I can tell you that yes, we do use it in bladder bleeding. No, if the bladder there is bleeding from the bladder, we give wash in solution mixed with tranexamic acid. Personally, I think it works. I do not know about RCTs, but personally, I think yes, it does work. So you give pressure and then you do it. Yeah.
Okay. Another one thing is sometimes in our dental clinics we get patients with acute infections. So maybe with severe space infection, which definitely we do in a hospital setup. So is there any? I mean, just imagine that these patients are having might have undergone some liver transplant or even renal or some. They are having major hepatobiliary conditions. Is there any a kind of an algorithm or a like how to what all clearances or what all things we should do?
Okay.
Yeah.
Okay. See, in a patient with renal transplant, okay, you have to know what drugs the patient is on. I specifically mentioned about the corticosteroids. If the patient is on a high steroid dose, you will have to consult with the nephrologist and get his opinion, or an endocrinologist and get his opinion whether this patient can go into an adrenal crisis. Because the dosage of prednisolone, which is used in renal transplant patient, varies according to the patient and according to his immune status. Chronically, a lot of patients will have only 5 milligrams, which actually does not require anything. But in a septic patient, if you're doing any procedure, we should be very careful, because they are the patients who are going to go into adrenal crisis. Okay. The other thing what you should look at is whether the patient is on what immunosuppressants the patient is on, like tacrolimus, cyclosporin. They all produce a very high chance of patient getting an acute infection post-procedure. So we'll have to be carefully give antibiotic prophylaxis. So the checklist, if you want to know, then a renal transplant patient obviously should be seen by the nephrologist before any procedure. Their renal functions will be normal, but still they would not want you to use NSAID post procedure. Okay, a clearance from a nephrologist would do in a renal transplant patient, and a clearance from the liver physician who is treating the liver transplant recipient would do in a liver transplant patient. Those are the two clearances which you will be looking at basically.
Thank you. See, actually, one was a typical case which happened few years back in Mysore. So there was a 20-year-old male IT professional who was relatively claimed to be a healthy person. So he came for some dental procedure, and given the dental procedure was done uneventfully, but he was prescribed medication, especially diclofenac orally. So the moment he took diclofenac, he had acute renal failure, and he had to be hospitalized, and he went into ICU, and is with great difficulty he recovered, taking a few days there, but uh, the just with a single dose of diclofenac, all this happened. So,
Yes.
what exactly could have uh,
Yeah. See,
happened?
this is typically described. This is, I mean, this is described, and there is, truly speaking, there is nothing that we can do about it. It is just that unlucky doctor's fate and that unlucky patient's fate. That is the truth, because a single dose of diclofenac, we have seen patients landing up with CKD. Okay, but then for that, if can you totally ban the use of diclofenac? You can't. So single dose, yes. The important thing is post diclofenac renal failure is how you manage that initial period is extremely important. There are various methods by which they increase the hydration of the patient. They try to decrease the chronic injury which the patient goes into. The problem is not recognizing it as early as possible. So we prescribe aceclofenac paracetamol and diclofenac paracetamol left, right, and center, everybody. Okay. So when if you really ask me whether there was a way to prevent that particular incident, the answer is no. And whether you can really, that's what I said. I want to ask you a question actually. Do you routinely, for an extraction, a patient comes to you for an extraction, otherwise a 25-year-old normal healthy male, would you do a HBV and a HCV before you extract?
No, sir. Not
No.
in dental practice. Maybe
Not in dental practice. Yeah. So it's something like that. So would you do would you do a serum creatinine before you extract in a normal patient? You won't. Maybe that patient's creatinine, an undiagnosed CKD patient can have a creat of 2.
Okay.
So there is no way to really get away from this. It is medical practice. You do it with good intention, and whatever happens, happens. That is the true answer to that question.
Okay. Thank you. So another doubt which a few dentists have is now, especially with this COVID pandemic, and most of us have received this COVID vaccination. So, does it have any renal or liver impact?
No,
Which
sir. No,
has
absolutely.
any NSAID related interaction?
No. Actually speaking, see, one thing what we found during COVID was actually an increased incidence of urinary tract infection. I mean, there was a paper in the American Urological Association, and that is something which we observed also. In fact, I was telling my people here that I'm seeing an increased incidence of UTI during the peak of the COVID. Post-COVID, 2 to 3 weeks later, yes, we were seeing an increased incidence of UTI. But whether it really impacts any other system like NSAID or renal function, no. The answer is an absolute no. The only thing which it does affect, as we know, are the lungs. Chronic damage are the lungs, and UTI happens, but then they do clear off with antibiotics and usual things. Yeah, 25-year-old mole without any comorbidities, we had a lot of UTI post-COVID.
Okay. Yeah, and the last question is like now, just patient has undergone liver transplant. Like how many days after that he would be considered safe to undergo dental extraction? Or
yeah, see, usually post transplant, no, be it liver, renal, we look at least 2 to 3 weeks time. 2 to 3 months time for their the immunosuppressants to kick in and to work properly. So very important.
2 to 3 months.
Yeah. 2 to 3 months is what we usually look at.
Thank you, Dr. Venkatesh. It was indeed an excellent to have you with us. So it was a very good.
I really did not know. I mean, first time I'm addressing a dental gathering.
Okay.
So I'm.
I think it's mainly because of your, as you mentioned, your childhood
It's
friend,
only
Shyam.
because of Shyam that
Yeah,
doing
Shyam.
this.
Okay.
You are always the best as usual.
I don't think he can tell anything else, no?
It's not exaggeration. It was actually the truth.
Okay, okay.
Yeah. So yeah, it was an excellent talk, Dr. Venkatesh. It
Yeah,
was very
yeah,
good,
yeah,
very useful, and your slides were extremely precise and to the point. And
No, I didn't want to. I mean, I thought, to be precise and concise
Yeah,
was
I
what
know.
I wanted. If I have achieved that, I'm
Yeah,
happy.
yeah,
Thank you.
that's what. So we thank you wholeheartedly from our SIG
Thank you.
team,
Thank you.
from the
Thank you.
JSS
Thank you very
Dental
much. Anything
College
else
and
that you want anytime? I mean,
yeah,
if you
sure,
want to address,
sure.
I will be happy to
Yeah, sure.
do this.
So
Huh?
yeah,
Any other questions also, we'll be happy to take. Yeah.
as
Thank
of now, chat
Yeah.
is nothing as such.
Thank
So
you. Thank
yeah,
you.
thanks a lot. Thanks a lot.
Thank
Thank
you.
you, Venkatesh.
Shyam, thanks a lot, Shyam.
Thank you. Bye.
Yeah, bye.
Thanks. Thank you.